I'll introduce myself briefly. Dave Maynor. I'm a pediatric otolaryngologist that practices at ENT and Allergy based in our New Rochelle office. Brief background about me, I went to medical school at the University of Rochester, and I got my Master's of Public Health there during my tenure as a medical student. And then I subsequently did residency at the Johns Hopkins Hospital in Baltimore, and then did my Pediatric Otolaryngology Fellowship there as well. I was in practice in the city for a few years, and then subsequently moved up to Westchester, where I'm originally from. So I'm looking forward to giving you guys a presentation. I always enjoy hearing about your interesting cases and seeing your patients, and I'm happy to assist you guys in any way possible. So today we're going to talk about acute otitis media and chronic otitis media with effusion, going through the clinical practice guidelines from 2013 and 2016. So these are actually some of my favorite articles, one of which was the Diagnosis and Management of Acute Otitis Media, partially because it was headed by my fellowship director, Dr. Tunkel. And this was a really good collaboration by the American Academy of Pediatrics with pediatricians and otolaryngologists and family practice physicians, and really coming up with a comprehensive guideline based on the evidence. And there's a lot of what we practice in medicine that hopefully is evidence-based as much as possible, and some of it is clinical instinct, and the best medley is when we have a combination of both of those in order to deliver the best care possible and make the best decisions we can with our patients. So the American Academy of Pediatrics published guidelines for acute otitis media in 2004, and then it was subsequently revised in 2013. There was a study that was done in 2007, Renaccio, and what was interesting about the study is they interviewed almost 500 clinicians that were surveyed about their practice patterns before and after the 2003 guidelines. Unfortunately, they found there was no significant change in practice pattern. So, not totally surprising, it does take time for practice to change, and things don't necessarily happen overnight, and sometimes clinicians are appropriately leery when they're just new guidelines with blanket statements. But it is telling in a sense that it is hard to change practice patterns, even in the face of sometimes good objective studies and evidence. So for the acute otitis media guidelines, the target population was children ages 6 months to 12 years of age. And the audience, appropriately so, were pediatricians, emergency department physicians, otolaryngologists, nurse practitioners, physician assistants, that all have an overlap in caring for these children that are affected by this ailment. And because we each play a very important role in the diagnosis and treatment of these children. When you look at these guidelines in general, they usually will weight the evidence based on the quality of the study and the recommendation it's based upon. So with the best studies that are labeled as Group A, that are well-designed, randomized clinical trials, diagnostic studies, and then for Class B, usually it's randomized clinical trials, but with some limitations, and that's the predominance of the evidence that you see in these trials, in these guidelines, usually is Class B. C is observational studies, and D is expert opinion, which is kind of the least weighted. So the conclusion of these guidelines is that there were 6 key action statements by the American Academy of Pediatrics for the treatment of acute otitis media. And we'll go through each of them as to why. So key action statement 1 was we should diagnose acute otitis media in children who present with these findings, which is moderate to severe bulging of the tympanic membrane or otorrhea that's not due to acute otitis externa, and this was grade B recommendation. Diagnose acute otitis media in children who present with mild bulging of the tympanic membrane and less than 48 hours of symptoms. This was a grade C recommendation. And most importantly is to not diagnose acute otitis media in children without middle ear effusions. And I think surprisingly, looking at ears is very challenging. When I teach residents and medical students, it is a very hard skill. And occasionally I have internists that come to my office and they just want to observe, and it's good because we can look with a microscope and camera and we can look at things up close. And one of the things I always challenge the residents during surgery with is before you put a tube in this child, tell me if there's an effusion or not. And when there have been studies that have looked at this, and it's about 50-50 in residents that are early on. I would say with me, it's probably closer to 90%, but it's not 100%. And it's a hard skill. But the trick, I think, with the first statement, it may be obvious, is to really diagnose acute otitis media in children who actually have the symptoms and exam findings to support it, not just one or the other. So how do we assess this? So impaired mobility of the tympanic membrane is really, really important because that gives us a clue that there's an effusion present. If there's full mobility of the tympanic membrane, that really gives us a very important diagnostic indicator that there's no effusion present. If there's no effusion present, then you cannot have acute otitis media. Pneumatic otoscopy is very, very helpful. The thing that's helpful about this is you could take it anywhere. It literally just attaches an otoscope. It's a bulb on it. And you create an airtight seal in the ear canal, and you push a little bit of air. If the tympanic membrane moves, that's a very good indication there's no effusion. If it doesn't, then you have to look more carefully. Probably that there's a problem with the tympanic membrane, whether it's effusion, a tympanic membrane perforation, or other reason why you're not creating a seal. So if you find this, it has very high sensitivity. It's like 95% and 85% specificity. It's one of the best tools we have. Cloudiness of the middle ear, it's reasonable, 74% sensitive, 93% specific. If you have bulging of the TM, there's really rules in the diagnosis. The specificity is not high, but the specificity is as high as you can get for any type of test. These are just some examples from the paper. So for the first one, for A, anybody know what ear this is? It's a left ear, yeah. Okay, the reason why it's a left ear is the tip, I don't know if you can see. So this is the umbo of the malleus. Okay. The ossicular chain, you could see the long process of the incus here, and actually the stapes is here. All right. The ossicular chain is always in the superior posterior quadrant, always. So that's how I always identify it, of which ear it is what orientation would that create with the ossicular chain is pointed superior posterior. All right, so it's a left ear. First one's totally normal. You have a light reflex, it's transparent, I could see the ossicular chain. If you could see the ossicular chain, it's not 100% certainty there's no effusion, but that's a really good sign that there's probably not an effusion. In B, you have minor bulging. You see some of the prominence, some of the visualization of the ossicular chain is not there. The malleus is becoming a little bit more obscured by the surrounding fluid. In C, we have moderate bulging. It's actually very hard to now see the impression of the ossicular chain. And D, we have severe bulging. So if you have someone who's in the B to D category and they're complaining of pain and fever, that really puts the picture together and cinches the diagnosis that you have acute otitis media. And half of the trick is really distinguishing this from chronic otitis media. In chronic, you're never going to have bulging ever, and we'll go through that in some slides. With acute, high likelihood that you will. So for key action statement 2, pain should be assessed and managed. I think this is one of the most important things that specialists in my field forget about, and I think sometimes pediatricians can sometimes forget, is that the most common reason that the child is actually presenting is because of pain and discomfort. So we should treat it. And analgesics relieve pain very easily, usually within 24 hours. And typically Tylenol and Motrin is more than sufficient to relieve pain from acute otitis media. And ideally it should be assessed and treated within 24 hours. Very rarely do you really need to give narcotics. I can't remember the last time I did in this scenario. There really has to be something else that's making the situation much worse. Key action statement 3. So antibiotics should be prescribed in the following circumstances. So children 6 months to 12 years with severe signs and symptoms, and that's just defined as moderate to severe otology for 48 hours with a fever of greater than 39. Antibiotics should be prescribed for bilateral acute otitis media in children less than 2 without severe signs and symptoms. And this is a concern for hearing loss, language acquisition, age if they were to get toxic at that point. Unilateral acute otitis media in children 6 months to 23 months. Bilateral acute otitis media in children greater than 24 months without severe signs or symptoms can be observed with close follow-up within 48 to 72 hours. So I think this is probably the third point, is the one that we all as clinicians could probably work better on, is the idea that not every case of acute otitis media needs to be treated with antibiotics, that some cases can selectively be observed, because there are certain situations that it'll clear up on its own, and many cases can be viral. So here's just pictorially from the guidelines. So if you have otorrhea with acute otitis media, you're 6 months to 2 years, antibiotic therapy is reasonable. Greater than 2 years, in this scenario, antibiotic therapy is reasonable. If you have a unilateral or bilateral acute otitis media with severe symptoms, as we described before, which is fever greater than 39 in the past 48 hours, persistent otalgia for more than 48 hours, or a toxic appearing child, then definitely antibiotic therapy. If you have bilateral acute otitis media without otorrhea in a young child, defined as less than 2, antibiotic therapy. Greater than 2, some shared decision-making with the parent, but observation is reasonable. And if you have unilateral acute otitis media without otorrhea, then shared decision-making is important with the parent. Whether the patient's going to realistically follow up is important. If there's any type of concern about that, then obviously you're going to be more aggressive with treatment. But if they're a reliable patient, they're going to come back in 2 days to be reassessed, and they meet this criteria, it's very reasonable to observe. So a Cochrane review was performed by Sanders in 2015. One of the studies that was cited was that 60% of children with acute otitis media were actually better in 24 hours, regardless of antibiotic was the treatment of choice. So the majority of these do get better without any intervention, and that's part of the reason for this guideline for unilateral acute otitis media without otorrhea in children. And antibiotics did not reduce pain in the first 24 hours. So, you know, the point really is that we should treat pain. It's a real condition in these children, and we should treat it with Tylenol and Motrin. But actually, many of these children, if they're not toxic, if it's unilateral, especially if they're older, can be observed. They did find that very mildly, it was a small association that there was some decrease in pain in the days following acute otitis media, but probably not sufficient enough to use it as a predominant reason to give antibiotics. Antibiotics may slightly reduce the risk of tympanic membrane perforation, not statistically significant. And you know, the question is always, well, I want to prevent mastoiditis. What's the chance I'm going to do that? You can, but it takes a very large number of cases to prevent one case of mastoiditis. So it's greater than 4,000. It's a very infrequent complication, truthfully. You know, probably, we were in a very busy center where I trained. We did a lot of ear cases. You know, I probably would say, on average, we probably saw 3 cases of mastoiditis a year that was real, that required an actual surgical intervention. So it's not common, but when it happens, it's real and can be very severe. But it's not a good enough reason to just give blanket antibiotics to everybody, with the risk of antibiotics, risk of allergic reaction, risk of resistance. So in terms of what antibiotics to give if we're going to treat. So amoxicillin is first line. Usually the standard dose is 80 to 90 milligrams per kilogram per day divided BID. Augmentin is a very reasonable second line, and this is defined as that the patient has received amoxicillin within 30 days or has purulent conjunctivitis, and to reassess antibiotic choice in 2 to 3 days if symptoms are worsening. So these are the most common organisms with both URIs, acute otitis media, sinusitis. It's all the same upper air digestive tract. So strep pneumonia seems to be decreasing now with vaccination, non-typable H flu, and then varicella. About 75% of children, interestingly, with varicella infected were cured with amoxicillin despite this bacteria showing resistance. So why? A lot of it has to do with duration. Antibiotic resistance is not a black and white issue. It has to do with mean inhibitory concentration. If you can exceed the mean inhibitory concentration in the bloodstream, then the bacteria will be knocked out. One of the things I've always lectured the residents on is if you have, for example, otitis externa, there's a good example of this, and you culture it and it's Cipro-resistant, people get very scared. Oh, I'm out of options. I only have Ciprodex and ofloxacin, and I don't want to give cortisporin. I don't know what to do. And what's interesting is, you know, many times if a bacteria is resistant, maybe you'll have an MIC of 4, 5, I don't know, maybe 10 if it's really resistant. But do you know what the mean inhibitory concentration is when you put drops in topically? like Ciprodex or fluoxetine? Over 200. All right, so even resistant things can be appropriately treated, but the concentration needs to be sufficient.
Question along those lines. So I saw the same data that suggested that H-flu and MCAT are kind of taking over and strep pneumonia is diving down.
Yeah.
So there's a suggestion, I don't necessarily agree with it, but I'm curious what you think about starting with Augmentin versus amoxicillin. Any thoughts on that?
I still think amoxicillin is reasonable so long as they're going to follow up properly. Because we know that, truthfully, the sequelae for short-term observation is low. You know what I mean? The trick is not to let them go, meaning that, you know, your amoxicillin, you're done, we're not going to reassess, we're not going to talk about it. We're going to follow up these patients. So I think assuming the patient has good follow-up, amoxicillin is really a very reasonable first line. Group A strep is really the minority of cases. And this, you know, all these serotypes, they change as more vaccinations come on, whether the patient has had tubes, so it changes the bacteriology of the disease. So this is pictorially. So recommended first line, you know, amoxicillin or Augmentin, but again, I usually do the least in sort of quote-unquote strong antibiotic as first line. An alternative treatment, if they're, let's say, penicillin allergic, would be ceftonir, cefuroxime, ceftriaxone. These are all third-generation cephalosporins. It's not a coincidence to that. There is very low cross-reactivity between these third-generation cephalosporins and penicillin. It's a misnomer to think otherwise. They are not the same molecular structure. There's very low molecular mimicry between the two. It is safe to use these as a safe alternative. If antibiotic treatment, if they fail, and you're reassessing them 48 to 72 hours, what's your next line? So Augmentin is very reasonable, especially if they've received amoxicillin, or ceftriaxone. This will be given either intramuscularly or intravenously over the course of 3 days. An alternative treatment would be a combination of ceftriaxone and clindamycin. That's a very good combination, especially for resistance things in the upper air digestive tract. We use these a lot, especially in residency and fellowship, for subperiosteal abscesses in children from sinusitis. And then you can give clindamycin this dose, 30 to 40 milligrams per day, divided in 3 doses, plus a third-generation cephalosporin. Of course, there's always the option of putting a tube in. We don't really do tympanocentesis, so to speak, that much anymore. It's not really practical because if you're already going to go to the operating room, then you might as well just put a tube in simultaneously so you can ensure that they can get appropriate topical delivery of antibiotics rather than having to continue with oral or IV antibiotics. But it is common that if we have a particularly resistant strain or mastoiditis, that we will culture the middle ear. And we have a very cool device that will do that, where we'll suction up the middle ear purulence, and then we can send it for culture.
One question
Yeah.
from, we have a lot of remote people watching.
Yeah, of course. Yeah.
From our various locations. So a question from our Mid-Atlantic team. In terms of otitis conjunctivitis, we've always been taught to start with Augmentin because
Yes.
of the high prevalence of H-flu.
Yes.
But could there be like adeno or other overlap, and then should we potentially start those patients on amoxicillin? Or?
I think you can't, it's very hard to parse it because you won't be able to culture.
Right.
So I think in that situation, the data is in favor of being more aggressive.
Starting with
Yeah,
Augmentin.
correct.
Okay. That's typically what we do. I just want to.
You're never going to be right 100% of the time
Right.
with any of these. You know, but the guidelines are designed to try to achieve being more right than not. So for what do we do for resistant acute otitis media? We spoke a little bit about this. So amoxicillin versus Augmentin, second line Augmentin versus ceftriaxone or Clinda. Bactrim's also reasonable in practice if there was a reason why you couldn't give the others. If you're going to give ceftriaxone, the general suggestion is to give 3 doses, either IM or IV over 3 days. IM, especially for little children, you can't get an IV practically speaking. And then ceftonir or ceftriaxone are reasonable alternatives if there's penicillin allergic. Again, there's really no significant cross-reactivities, and the studies are very clear on this point.
Sorry to keep.
Yeah, of course, that's okay.
A lot of questions. Just back to that last
Sure,
slide.
yeah.
So I've seen some, and I do this as well. Sometimes a patient will fail Amox, fail Augmentin, but the patient is kind of, or the parent doesn't necessarily want to give 3 IM shots 3 days in a row.
Yeah.
Could you try ceftonir? Is there any?
I mean, the guideline doesn't really suggest that, going sort of back, so to speak. But, you know, I think if the patient is going to be observed closely, it may not be unreasonable. But if they've tried other antibiotics, ceftiofur is really more of an alternative rather than a step up, so to speak. Yeah. For key action statement 5, so antibiotics should not be used for prophylaxis, meaning to reduce the frequency of acute otitis media. And then when do we put tubes in? So this is one of the most frequent consults I get in the office. So typically the guideline is 3 episodes over 6 months, 4 episodes in 12 months. And what are some increased risks for acute otitis media? Being in daycare, exposed to other children, secondhand smoke is a very, very, very strong risk factor for it. So if there's an opportunity to counsel parents to quit, this is one. Being in the winter, being a boy. And then for 6, so pneumococcal vaccine is recommended, right? We know this reduces the frequency. Influenza vaccine is recommended with the idea that if you get sick with the flu, you're going to have eustachian tube dysfunction, and that could lead to acute otitis media. Exclusive breastfeeding is encouraged for at least 6 months. That's a grade B recommendation for antibody. And recommend avoid passive tobacco smoke. So that's grade C. So what do you do if you have a ruptured tympanic membrane? So one is prescribe otic drops. Really, really important, super simple. There's really almost no risk whatsoever. It probably doesn't really matter whether it's ofloxacin or ciprofloxacin. Usually ofloxacin is a little bit easier to get through the insurance. Typically it's less expensive, and that's sufficient. And it's not an exact science with the drops. I usually recommend somewhere in the 4 to 5 drop range, BID to TID is usually sufficient. I feel like the younger the kid, you might want to increase the frequency because maybe the likelihood they won't really do the full dose may be reasonable. Avoid aminoglycosides. So one of the problems is that neomycin polymyxin, otherwise known as cortisporin, is very cheap and typically always approved by insurance, but there is always a fear with this medicine that it will cause ototoxicity. So really this drop should be reserved in cases when the TM is fine. So meaning you have otitis externa, you can see the tympanic membrane, it is closed, there's no perforation, then that's reasonable, but otherwise this is to be avoided. Definitely should refer to ENT at this point. This is reasonable, and the reason why is that a perforation may signal some other pathology. It could be as simple as acute otitis media, but it could be cholesteatoma. There could be a lot of different, it could be oral polyp. And distinguishing these is very, very important because it changes dramatically the surgical management for these patients. And once the otorrhea resolves, then we get an audiogram to see what is their baseline hearing. Will the perforation close and their hearing improve, or will it not? And do they need a tympanoplasty at some point to repair the eardrum? So those are important questions to be sorted out.
What would you recommend telling parents, because they usually come in and you tell them your eardrum is ruptured, they get a little bit
So in all likelihood that it will close on its own, statistically, but it needs to be cared for, it needs to be debrided, we need antibiotic drops to maximize the chance of that happening. If you were to get an audiogram for a tympanic membrane perforation, they probably will have conductive hearing loss, but it can actually vary. So one is how big the perforation is and where the location of the perforation is. So if it's where the ossicular chain is, there's a much higher chance that you're going to have a conductive hearing loss than if it's actually very far away from the ossicular chain. So I've seen medium-sized perforations that produce almost no conductive hearing loss just on the location, and some that are very, very small, but they happen to be in a non-ideal location that produce quite a substantial conductive hearing loss. Yes?
Sorry. Just going back to referring to ENT for the otorrhea.
Yes.
Do you want that should that be during the acute illness? Or?
It's totally fine either way.
Do you mind repeating the question?
Yeah, of course. She'd asked whether ENT referral should be done during the acute illness or afterwards. I think either is totally fine. One of the benefits that we can offer during the acute illness is I could debride their ear. And that can, one, try to reveal what the pathology is, and also many times when otic drops are not successful, the reason why they're not successful is there's too much otorrhea in the ear for the drops to get to the spot that you actually need them to. So sometimes just debriding the ear out well, I put in 1 dose of drops in the office and have the parents do it. Usually, honestly, the dose of drops in the office is probably the most effective, just getting it once right where they need to be and having them lay for a few minutes.
Just a follow-up question.
Yes.
Are you still doing the
So if they have otitis externa, isolated otitis externa, they do not need oral antibiotics, ever. It's assuming there's no other systemic issue going on. If they have acute otitis media and they have a patent tympanostomy tube, they only need otic drops. They never need oral antibiotics unless there's some other systemic issue, like i.e. they have bronchitis and now they also have acute otitis media because of the eustachian tube dysfunction from that, then that's reasonable. But if it's isolated acute otitis media with a patent working tympanostomy tube, otic drops is the only thing they need. Yeah.
What if the discharge in the external canal is so copious that? So my question was, if the discharge in the, oh my gosh, wow. If the discharge in the external canal, I always get worried that maybe the drops won't get to where they need to go because there's so much discharge there that I tend to want to do oral antibiotics. Is that not necessary?
You can if you're not sure what the diagnosis is, meaning like otitis externa versus acute otitis media. Sometimes it can be blurred in that situation because you can't see the eardrum. But perfect opportunity to send to me. And I'll look with a microscope to breathe the kid's ear out, and we'll sort it out.
The third scenario, if it's otitis media with a perf, just to follow that line, it would be drops and oral?
Typically in that situation, I think oral is probably more reasonable. The only reason why is, perfs like to close, and in all likelihood, the perf will close prematurely, and as a result, the drops may not really be effective ultimately. Yeah. They can, yeah. It's like this general rule in surgery. Things that things that are meant to be closed like to remain closed, and things that are open like to remain open. And I feel like in surgery we always fight this rule. Yeah.
So when we see a patient who comes in with a perfed TM,
Yes.
is that something we can tell them typically it closes within a few days, or it often closes on
Yes,
its own?
that is an accurate statement.
Okay.
But whether it will close in that individual person is highly dependent. I've seen really small perfs that I've been sure will close that never close, and then I have to repair them. I've seen gigantic perforations that I'm certainty will need surgery that end up closing.
And we should send those patients
Yes.
to you?
Anybody who has a perf should 100% be evaluated by ENT, because I've seen, where I would say that I've seen the failures happen is undiagnosed cholesteatoma, where someone had a perforation, they assumed it was like acute otitis media or externa, they saw a perforation, they just thought it was a simple perforation. It wasn't such a simple perforation. But a perforation is never normal, especially for long term. If you ever diagnose it, you should definitely send to me.
Question from
Sure.
another remote question.
Yes.
Dosing for clindamycin for otitis media, is it the same as any other oral dosing?
Yeah, I think it's the recommendation is like 30 to 40 mgs per kg. I always have to look back because I don't prescribe it often, luckily.
Okay.
Yeah, so 30 to 40 mgs per kg per day in 3 divided doses. Yeah. Sure. And then, otitis externa media are generally considered distinct entities. But the one thing that can sometimes confuse the picture is when you have myringitis. So myringitis is like an inflammation of the tympanic membrane, and sometimes that can cause weeping of the tympanic membrane. And that sometimes can muddle the picture a little bit. But if possible, it's very unusual to have both conditions simultaneously, if that makes sense. So it's usually media or externa, but it's not usually both. So the next guideline I want to review is the clinical practice guideline for otitis media with effusion. And this was considered an update. This was also a very good collaboration between otolaryngologists and pediatricians. And it's kind of the other side of the coin of acute otitis media. So chronic otitis media with effusion is defined as the presence of fluid in the middle ear without signs or symptoms of acute ear infection. So it's different. And this guideline had 4 new clinical practice guidelines, 20 systemic reviews, 49 randomized controlled trials. It was a pretty comprehensive study. So otitis media with effusion is considered the occupational hazard of early childhood. Over 2 million cases are diagnosed annually, cost the US a ton of money. 90% of children have otitis media with effusion before school age. So it's very common, very prevalent. Every pediatrician will see it at some point. Why does it occur? It may occur due to an upper respiratory infection, eustachian tube dysfunction. This may follow an episode of acute otitis media. That's probably one of the more common scenarios. Usually occurs most often between 6 months and 4 years, but it can occur anytime, including in adulthood. If you were to randomly screen children for it that are asymptomatic, give or take 1 out of 8 have it, so it's high. By age 2, 60% of children will be diagnosed with otitis media diffusion at some point. The good news is that most episodes resolve. 30 to 40% of these children will have repeated episodes, 25% for greater than 3 months, 5 to 10% of these otitis media with diffusion episodes last more than a year. It's one of the most common causes of hearing impairment that we see in children. Permanent hearing loss is very, very rare. It's not 0, but it's exceedingly rare, somewhere in the order of 2 per 10,000. Common symptoms overlap with acute otitis media, and that's where sometimes the picture can get confusing. It can present with otolgia, sleep deprivation, behavioral problems, speech and hearing concerns, rarely balance symptoms. What are the risk factors? Young age, the same thing with acute otitis media, is usually a flatter angulation of the eustachian tube. As a result, the middle ear doesn't pressurize. When the middle ear doesn't pressurize appropriately, it fills with fluid. When it fills with fluid, it can become infected or may just become stagnant. Male, attending daycare, this last one, supine bottle feeding, maybe. There have been some observational studies that have suggested that it may create a backflow of milk into the eustachian tube and then create an effusion that way. But it's probably not a good idea in general, but whether it's truly causative. We know that breastfeeding does reduce the risk. There actually are some interesting studies about limiting pacifier use, that if you limit it, about 30% decreased risk in infants less than 18 months. People think also it has to do with kind of sucking secretions into the eustachian tube. So I like this picture a lot because it's some subtle examples. So this first one, the eardrum looks pretty normal. It's transparent, you have a light reflex, you see the ossicles really well, but you see some subtle bubbles here. So this person does not have acute otitis media, they have otitis media with effusion. And my guess is if you were to get an audiogram on this person, it actually would be probably close to normal. It's very clear, the fluid, it's not completely prevalent. This is a really good example, right? With bubbles everywhere. Many times for otitis media with effusion, you don't have bubbles, but if you have bubbles, it's a sure sign that you have otitis media with effusion. This person, I guarantee you, has quite a substantial conductive hearing loss. The thicker the fluid, the more likely the conductive hearing loss. So acute versus chronic. So these are the distinguishing factors. So the first one is chronic, right? We have bubbles, we have fluid. The second one, we have bulging, okay? And like we talked about before, bulging is acute otitis media. You will never have bulging in chronic. Right? Chronic is not an infectious etiology typically. Otoscopy can be very helpful in distinguishing, meaning that you have fluid or not, but this is where clinical acumen comes in. Is the TM bulging? Is it red? Does the person have fevers? Are they in significant pain? And that to cinch the diagnosis of which one it is. So this is like the big guideline global picture. We'll sort of piece it together of what to do, but it's a good decision tree. We'll go through it. You guys will be experts. All right, so who to screen? So if you have a patient diagnosed with suspicion of otitis media with effusion, we're going to perform pneumatic otoscopy. It can be easily done in the office. If you have a newly diagnosed at-risk child, so this is important too, because children that are at risk for language delays, all right, we want to be more aggressive with those children in diagnosing, because any lost time with them developing language is even more hurtful in that patient population. So that includes people with permanent hearing loss from some other cause, speech and language delay, autism, other craniofacial syndromes that we know are associated with eustachian tube dysfunction, such as Downs. If they have other sensory issues, meaning they're blind or visually impaired, they're more reliant on hearing in that situation. Cleft palate, because we know virtually 100% of children with cleft palate have eustachian tube dysfunction, or other developmental delays. So we perform pneumatic otoscopy, and we determine whether otitis media with effusion is present. If we're uncertain, this is where what we can do in the office is we can perform tympanometry, where we see does the eardrum appropriately move with a small sound signal, and we can actually graph it, and we'll show you that. So children should be screened with pneumatic otoscopy to assess if they have otolgia, suspicion for hearing loss, or an at-risk child. And then I could show you what pneumatic otoscopy looks like. So this is just from YouTube, but it's a good example. So he's making an airtight seal. You guys able to see the subtle movement? All right. You guys want to see it again? Yeah? Okay. Yep. This is a very good rule out for effusion. If it moves, there's no effusion.
Only a small amount of pressure is required to achieve movement of the tympanic membrane. A slight movement in and out of the tympanic membrane can be seen on a pneumatic otoscopy, indicating air.
Perfect. And then let's see. Okay. So for pneumatic otoscopy, sensitivity is 94%, so it's very good rule out. Specificity is 80%. So if we're not sure in our office, for example, we'll obtain a tympanometry. And this is what we'll get in the office. So we get an objective test of middle ear function. This is not an audiogram, okay? This is an objective test of whether the eardrum moves appropriately. We put a 226 hertz tone is generated, and the energy is then reflected back by the tympanic membrane, and then this is graphed. So we have pressure and compliance. Ideal scenario is A, that's the green one. That's normal. It peaks at 0. AD is basically like an exaggerated compliance. There's a lot of debate as to what the meaning really of that is. Maybe the cyclic chain's a little bit more mobile than it should be, but it doesn't have clinical significance. AS is normal, but the compliance isn't quite as high as we hope. B is flat. B indicates that there is no movement at all. So this can be from either effusion or perforation or a tube that's working. So the clinical scenario is important to distinguish this. And C is it peaks, but it has negative pressure. And that usually is a very strong indication of eustachian tube dysfunction. And that may or may not have an effusion present. So infants with otitis media with effusion who fail, let's say, newborn hearing screen at the hospital, need to have follow-up to ensure the hearing is normal. And that intervention with infants less than 6 months old with sensorineural hearing loss reduces potential side effects on speech and language. And otitis media with effusion, we know, is a cause of transient, moderate, usually conductive hearing loss in newborns. So infants greater than 6 months with bilateral otitis media for effusion for at least 3 months and changes in hearing should be offered tubes. That's the criteria that we do. But the most important thing is that they need to have changes in hearing. So children that have otitis media with effusion and their audiogram is normal and they're asymptomatic, we can just observe this safely. But it needs to be observed, and they come in consistently. I usually see them once every 3 months or so to ensure that resolution, usually by 1 year, it will completely resolve. But if they have changes on hearing, changes on an audiogram, then it's a different story. So in terms of the risk factors that we talked about for speech and language today, all these patients should be evaluated for otitis media with effusion. These same children should be reevaluated at 12 to 18 months of age for effusion. And middle ear effusions, they degrade auditory signals. It's like hearing underwater. They cause difficulties with speech recognition and perception. So otitis media with effusion may occur with or without hearing threshold changes, which we spoke about. Positive predictive value of a type B tympanogram, that's the flat one, for pure tone hearing loss worse than 30 decibels, which is considered a mild hearing loss, is a little bit less than half. And then if you have asymptomatic otitis media with effusion, but without hearing changes, these should be observed. All right? There's not acute otitis media. There's nothing, we don't need to put a tube in these children right away. It could be 100% observed. Yeah. Okay. So 75% of children with otitis media with effusion resolve within 3 months after an episode of acute otitis media. About half of these children with spontaneous otitis media with effusion resolve within 3 months if the date of onset is unknown. 90% of children will resolve within 3 months if the date of onset is known. So basically the takeaway message is that most of these cases resolve within 3 months. Now on average, if you have an effusion, it produces a 28 decibel hearing loss. So this is significant. And shouldn't be snuffed at. So clinicians should manage non-at-risk children with watchful waiting for 3 months from the date of onset. And that's very reasonable and conservative management because most of them resolve. So just put a different way, if you had 100 children that was diagnosed with otitis media with effusion after an acute otitis media episode, and a type B TIMP, half will have improved by 3 months, 72 by 6 months, and basically most of them will resolve by 12 months. Children are less likely to resolve if it's during the summer or fall months. I think the rationale being those are the good months, so to speak. So that's when you should be doing your best. So if during the best seasons you're not doing so well, when you go into the winter season, you're going to do worse. If you have greater than 30 decibel hearing loss, that's considered conductive. And then if you've had prior tubes, that's also basically a marker that you have eustachian tube dysfunction. So what do we do for otitis media with effusion? So one of the most important things of these guidelines is not to treat these medically like this. So antihistamines, decongestant, reflux medicines are not effective for this condition. They should not be given. There's a strong recommendation against. Now, there are exceptions. So if you have really large adenoids and you have a lot of drainage in your nose, that's a good reason to give some of these, but it's for that cause, not for the otitis media with effusion. The two may be linked. Oral steroids have a very short-term efficacy. It is not a long-term solution. So you may see a transient improvement for 1 to 2 months and then recurring back to the effusions. Antibiotics, generally speaking, really do not have a substantial effect. They have a very small benefit when you look at the studies. And my general consensus and recommendation would be not to give antibiotics for routine otitis media with effusion. So at-risk children with otitis media with effusion and children with otitis media with effusion greater than 3 months of observation should be offered an age-appropriate hearing test. So if you see these children, in pediatrics, one thing to inquire about. So screening typically starts with the pediatrician. Usually they do what's called otoacoustic emission screening. They'll usually test for 4 frequencies. If they are not able to hear less than 20 decibels of loudness in at least one of the frequency, we call that a refer. Common terminology here in the community is a fail. I failed my hearing test, but actually the test is not designed that way. The test is designed to refer, meaning that more further audiologic evaluation is needed, that the test is intentionally designed to overcall hearing loss. Because we don't want to miss any child that has potential hearing loss when we can catch it. So very commonly, children will come see me for a refer on hearing screen. Their audiogram will be normal, and that it is a totally and complete appropriate use of the test. For children that are not able to do an audiogram for various reasons, we can do an auditory brain response in the office if they're really young. Usually we have the mom sleep deprive them. They fall asleep, and we put electrodes on them, and it's an objective response of hearing. For children that are able to cooperate appropriately, we could do visual response audiometry where we condition the children, behavior response for a little bit older, and then a comprehensive audiogram. Most children over the age of 4 can easily do it. So just to give perspective, so when we look at an audiogram, it's done in decibels. Decibels is a logarithmic scale, and it's done this way so that we can actually look at it on one sheet of paper and not have to have a whole scroll. Every 3 decibels increase in hearing, meaning improvement in hearing, is doubling of the perception of loudness. Okay? So when you have a 28 decibel loss that's documented on a hearing test, that is a substantial amount. That means that child is really not hearing appropriately. It's not to say they can't hear. They can hear, because most normal speech is in the 40 to 50 decibel range, but they're not hearing appropriately. And it'd be the same thing, if you required glasses and I decide to take your glasses away, and you might be able to see, but you can't see well. And during these critical years of language development, it's very, very important. So children with chronic otitis media with effusion need to be reevaluated, as we talked about, until the effusion resolves, a hearing loss is identified, or there's some other structural abnormalities. And then when do we offer surgery? So children less than 4 years old, the typical surgery we'll offer in this scenario is tubes without adenoids. In children greater than 4 years of age, you have a couple choices. You can either offer tubes alone or adenoids alone, and there's actually comparable success, but the reason why we typically will do tubes is because there's less risk. Anesthesia is quicker. They could be asleep for only a few minutes while we put the tubes in versus, adenoids is about a 20-minute surgery or so. Requires an endotracheal tube. Tubes and adenoids. So the only group that benefit for doing both of these is children greater than 4. So it's not that this is mandatory, but it's something to be considered, or if they've had relapse in otitis media with effusion, meaning they had one set of tubes and now you're going to do a second set of tubes, at that same time you might want to consider removing their adenoids. What are surgical complications of putting tubes? So these are things you might see in PM pediatrics as the first kind of line of therapy. So otorrhea from the tube. That can be from acute otitis media. The benefit is if you have a tube and it's functioning and it's draining, otic drops all the way. So ofloxacin, Ciprodex, we just want to avoid cortisporin drops. They do not need oral antibiotics in that scenario. If you have a tube that's obstructed, so this is unfortunate if that happens in some patients. Otic drops sometimes can be helpful. You're not really doing it for the antibiotic purpose. You're just doing it as a way to dissolve whatever the obstruction is, whether it's blood or cerumen. You can do other things too, like baby oil, mineral oil, maybe a little bit of hydrogen peroxide. Premature extrusion. Luckily, this hasn't happened to me too often, but it can. For whatever reason, it gets rejected by the body. The tube falls out earlier than you want. Maybe it needs to be reinserted. Displacement into the middle ear. I've seen this happen before for other people. Luckily, this hasn't happened to me, but sometimes the eardrum can close over the tube, and then the tube would need to be removed because otherwise it will cause a conductive hearing loss. And a persistent perforation, usually in the 1% to 2% range. Typically, if we have to do laryngoplasty or tympanoplasty, usually 90% success in the first try. So as we spoke about before, children with otitis media with effusion have an average hearing threshold of 28 decibels. 20 is considered normal. Usually, young children can hear usually at 0 or 5 or even 10 decibels. So this correlates with at least an 8-fold decrease in sound intensity. So 8 decibels is a lot. All children with otitis media with effusion with hearing loss prior to tube insertion, they need to have an audiogram afterwards to ensure that there's resolution, because I have caught sensorineural hearing loss this way. So meaning a child presents, it's very hard to do bone thresholds in the office in a young child. They have an effusion. You suspect it's conductive. You put the tube in. You get the repeat hearing test not improved. And that's a child who probably had 2 conditions. They probably had congenital sensorineural hearing loss, and they also had an effusion, which we know is common. So any questions about the guidelines? Once you take it apart, it's not so complicated. Yeah?
So I think the most common way that otitis media with effusion affects us is we just pick it up incidentally.
Yes.
So, a kid comes in for cough congestion and we see some fluid bubbles.
Yes.
Yeah. At that point, should we just, obviously let the parent know and then refer them back to their pediatrician for a repeat?
I think that's totally reasonable because most of those will resolve, but they need to be followed though. That's the key, is we don't want to just assume that the hearing is fine. So if the effusion persists, because I have caught this also in asymptomatic kids before. They come in for something else, maybe tonsillar hypertrophy or sleep apnea or whatever, and I look in their ears and they have effusions present, and I get an audiogram, and in fact, whoa, they have quite a substantial conductive hearing loss that the child didn't appreciate because it's probably been this way for a long time. To him, that's normal, but in fact, that's not normal.
Yeah, so let the parents know that this can actually impact hearing.
Yep.
Make sure to follow.
And certainly if you're able to pick up that they happen to have speech delay too, then that's even more reason to get a hearing test. Yeah. Any other questions? Yes?
Going back to acute otitis media.
Yeah.
With bullous laryngitis,
Yes.
as an indicator of a typical infection and to need, let's say, a macrolid, what's your thought on that? Is it still going to be overwhelmingly the other bacteria and stick with amoxicillin, or?
I think it depends. If there's really no effusion and it's really a laryngitis, which is really a TM issue, the otic drops usually is sufficient for it. If it's a laryngitis issue, but I think you have to really distinguish that. If you're not sure, then I would err on the side of oral antibiotics. You know what I mean? So if it's bullous because there's an effusion present and because there's acute otitis media and that's causing inflammation in the TM, then oral antibiotics and augmentin's reasonable.
But you're not concerned about the possibility of mycoplasma to need?
I think it's very unlikely. It's not 0, but it's very unlikely.
It's because growing up,
Yeah.
my hair is gray. We were told if you had that, we used to use Pediazole, erythromycin sulfa.
Yeah, I would say the studies probably don't support that really.
Okay.
But it probably will be effective in treating it. Even generic, so to speak, the common organisms of acute otitis media, treating that.
It's funny, I remember reading the same thing when studying for the boards. It was like it was boards world versus real world, which is, if you see bullous, otitis media, then you should treat with a macrolide, but it doesn't seem to play out.
You lose everything else.
Exactly,
Right,
exactly.
yeah.
So every time I see it, I think of that board's question, and then I just disregard it. And
I mean, another
watch it.
classic scenario too, is especially with foreign individuals, is if you see a bilateral tympanic membrane perforation, you should think about tuberculosis a little bit. It's not to say that's the most common cause. It's not. Probably poor medical care is the most common cause of what led to that, but it should be kind of in the differential to think about. Any other questions? Thank you guys so much for the opportunity to speak.